Welcome to Care Transitions Today, Case by Case, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we take a fresh look at the real-world challenges of case management related to care coordination, patient transitions, utilization management, and complex discharge planning. Today, we are joined by Dr. Rebecca Severe and Dr. Sweta Singh. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Whether you're a physician, case manager, or leader in case management, this season provides valuable insights to navigate complex patient transitions. This is Care Transitions Today, Case by Case. Let's begin the discussion with our first case.
Hi, Rebecca.
Hi, Sweta.
Are you ready for an OB case today?
I will try. I know we don't get a lot of those, so hopefully I'll be able to, answer your questions.
Yeah, no, we have, again, in terms of volume, for sure, medicine is highest volume followed by surgery, but we do have some OB cases as we have a big Children and Women's Center.
Okay.
And we have an OBPA who was able to add on some interesting facts. So I thought this case would be interesting to discuss. So I have this 35-year-old patient with a history of Gravidan9 P1070 at 25-week by ultrasound with pregnancy complicated by short cervix, which is 17 millimeter, and fetal NTD. So she presented with fetal ultrasound showing fetal feet in cervix canal. She had the NSTs done on day 1 and then again on day 2. So care started 10th of January. She had another NST on 11th of January and then was discharged on 12th. Given the bedside ultrasound with cephalic presentation in the morning, with no appreciated dilatation of the cervix and did get betamethasone, so was discharged, felt to be safe and was discharged. Now this patient met inpatient by interqual, but it's about 3-day length of stay. Came in on 10th, discharged on 12th. What would you recommend? Downgrade to OBS, and this was denied by the pair.
Yeah, I guess I'm not shocked that you're telling me you got a denial on it. I mean, oftentimes we're dealing with a Medicaid payer or we're dealing with a commercial payer for the OB cases. Every once in a while you'll get a Medicare payer, but I do find that, cases that come and go in about 48 hours are really hard to get approved as inpatient, probably more so with my Medicaid payers, just because they, at least for my state where I practice it, they are pretty rigid around the 48 hours. And, you have to really go past that and show a persistence of something, even if it's maybe meeting one of your commercial criteria, vendors that you may use for that particular payer. So we may try, our UM team, if they meet, whether it's interqual or MCG, our UM team will often make them inpatient. And then we just try to, retrospectively, if we get the denial, we try to sort it out. Sometimes we'll still try it. I would say what you've told me is probably one I would have had a hard time getting overturned, to be honest. What we oftentimes will see, like very same scenario, the patient comes in, they maybe get the steroids for a couple of days, but then it's determined they need to stay in the hospital until delivery. but not much is happening other than they are hanging out in our hospital. We will also see that type of denial quite frequently. And that one can be sometimes challenging to appeal. But in my experience, since I'm not OB, I will oftentimes reach out to our perinatologist and be like, help me understand why this patient has to stay in the hospital till they deliver. Can you put in the statement? What are you worried about? What is the risk to the mom? And I found that to be a really helpful tactic when you get these really long OB stays and not much is happening, but there's a lot of risk for something bad to happen. So I don't know, did you end up doing the peer-to-peer on this one, or what did you do?
Yeah, we did end up doing the peer-to-peer on this one. And what we discussed about is this is not your usual pregnant lady coming in with possibility of like, oh, is she going into labor or not? This is a high risk, very high risk pregnancy. She's 35 and is gravida 9. So this is her 9th attempt. And there was complication of the short cervix. And that's why patient did get the NSTs done on 2 consecutive days. And usually if someone gets 1 dose of IM betamethasone, we're like, okay, to accept it as an OBS. But if they end up getting 2 doses and daily NSTs, then we try basically push for it, and that's what we argued for, and that this patient did end up getting both doses because we were very concerned about. So these are not feasible to do in an outpatient setting, and that's what was discussed, and yes, it was approved in peer-to-peer based on this.
Good, yeah.
Though it was a short length of stay. Primarily, like I said, because this is your pretty high-risk pregnancy and there is some visible complication that was concerning. And that's why, along with that, so basically going by the 3 basic rules, there is a medical necessity for patient to be in hospital. There was severity of illness. There's risk of baby dying here. And in order to mitigate that, there was enough intensity of services with NST monitoring and IM betamethasone. With this high risk, severity of illness, we were able to get this overturned in peer-to-peer. So I wanted to also bring this case up for 2 reasons. Sometimes, a lot of time we get burnt by or be like, oh, something is short stay. Then we start going towards, oh, this will be OIB or OBS because it's a short stay. But they're still worth discussing, especially when we have these very high-risk pregnancies.
Yeah, and that brings up another good point. One of the other risk details that I found helpful for our OB cases, one of our hospitals is an inner city hospital, and we will see this not infrequently, is that oftentimes there's social factors that add to it. So you may have the same scenario, but maybe this patient has a substance use issue that's complicating the pregnancy. Maybe they're unhoused as well, and that adds to the risk. So I find that sometimes reading my social worker notes along with the medical notes, I can establish it's higher risk. And especially, as I mentioned with my earlier example of sometimes you'll even get into it, it goes past 48 hours, but you have to make the case, why did they need to stay in the hospital? And I think those social factors as well can help support it. Or again, getting more in the chart from your, perinatologist, your OB about why this patient is so high risk, so that since I'm not an OB or perinatologist, I find it helpful to be able to say, I talked to that person and I got this in the chart. And I've even had them quote studies and, give me actual numbers around the risk. And I found that really helpful too. So.
Oh, absolutely. Sometimes when I'm reading OB notes, I'm trying to remember everything from my med school, and it's I think it will be easier. Let me just talk to someone.
Yes, phone a friend. I definitely, that is one of my rules around OB cases. I will know my limit and know when to reach out for some expert advice. So yeah, another good case. Thank you, Sveta.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. ApplePalm is inclusive of all practice settings. Membership in ApplePalm also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, ApplePalm membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more.
And I think you have a good case for us too, Rebecca. You want to go with your case now?
Yeah, this is a new one for me as well. In 2026, I don't know if you've been seeing this, but we've had one of our major payers implement a severity payment policy that was very different. I know I've heard others across the country have been encountering this with other plans. So I wanted to share a case and kind of get your take on how maybe you're managing it, if you're seeing it as well. So the case that we had, this is a Medicare Advantage plan that's implemented this for us. And the patient had AFib. They had a high CHA2DS2-VASc score of 7. They'd had a prior stroke. It required emergent thrombectomy in the past. They'd also had issues with recurrent falls. And so they were determined to be a patient that is high risk for needing to not be on anticoagulation. And so they were going to do a left atrial appendage occlusion device for this particular patient. So that procedure did occur, but it was a 1 midnight stay for this particular patient. And according to the payment policy that's in place, this plan will issue either a high severity or a low severity payment for different stays. So they gave us a low severity payment on this. So yes, it was inpatient, but low severity payment for this particular payer. So I took a look at the case and I felt like, yes, they gave me inpatient. It was an inpatient only, so I know it has to be inpatient, but I felt like even though it was short stay, we should be getting that full inpatient, DRG payment. So I did go ahead and request a discussion with my payer on this particular one. So I'm going to stop there and kind of see your reaction and your thoughts, or maybe you would have said, hey, it is a short stay, knowing, these payer policies, it's not worth it. I guess, what would you have done if you had gotten the same case scenario?
I would have done what you're doing, which is not accepted as a low payment model, primarily because, like we did before, which is if it's an inpatient only procedure, getting admitted, it's an inpatient stay. Now, the payment model can vary in inpatient by the payer, saying it low severity versus high severity, but what it looks like is similar to what you're arguing for is OIB versus an inpatient for the stay. And this is an inpatient stay. If that equates to high severity payment, then it is a high severity payment, regardless of length of stay. And that's where, when I first saw the policy of changes happening, and it said, okay, for length of stay, 5 days or 7 days, if it's less than that, if things will be, unless meeting criteria, be changed to low severity, I reached out to our contracting and asked them, can we request clarification, and is this acceptable? Now, there's not much we can do on the contracting side, but we could find out is that we could still do peer-to-peer and appeal those decisions. Mm-hmm. So like you rightly said, I would have had the same approach, which is discuss with the payer or take it to the peer-to-peer or appeal for that decision of low severity payment. I would take it to this should be a high severity payment, like a original or the previous inpatient, true inpatient.
Yeah, and actually, this case turned out to be pretty easy. Like I was worried I'd get pushback based on length of stay, but when I requested that severity discussion with this particular payer, I actually, even before I had to do the peer-to-peer, I got an email back saying, hey, we've overturned it. So I think they'd actually given us inpatient auth to begin with prior. So I think in their process, they failed to recognize it as an inpatient only. And thankfully, when I requested, someone took another look at it and I think appreciated it was an inpatient only, and we did get high severity. So this one was an easy one. But I think for us, having to manage a new payer policy like this, for us has been kind of we've had to really rethink our whole process, both front end and post claim. I know for us concurrently, we've had to put in some new processes in place with our team to be aware of the nuances of the rules to make sure that, for example, for this particular payer, if they have a length of stay of 5 days, that has been deemed appropriate for that high severity payment, even if they didn't otherwise meet a particular inpatient criteria. So we've implemented a process where we communicate back to that particular payer in an efficient way. Hey, this patient has hit that 5 days. You previously had told us it was low severity, and then we've been getting that approved for high severity. So we didn't want to leave that to just chance. And so we developed like an efficient way through our EMR to kind of automate. Well, it's not automated. We have to have a little bit of a human touch, but we have a couple clicks. We can push that message back out to the payer so that they are staying on top of these particular cases. And even I know for our physician advisor team, we keep their particular rules in mind when we may use that length of stay as part of our argument when we go with the payer. Maybe we wait if we're getting the denial or the not a denial, it's not a denial, but a downgrade, and it's hospital day 3 or 4, they're not discharging. We're not going to like automatically downgrade it. We are going to wait and see how that case plays out. So definitely for myself and my physician advisor team, we've had to kind of think about things a little bit differently. And the other thing, I think it was good that you mentioned this. I think we did go to our contracting as well, because I think for each hospital and health system, when you encounter one of these plans, I think you do need to go to your contract and understand, is there any language in your contract that maybe prevents this from even occurring? And potentially you need to leverage a conversation with your payer that ties back to your contract. So I think that was a good point that you brought that up too. I mean, other thoughts on this one were like how you're managing on the back end post claim?
We have the claim process is a little bit delayed, so I'm still waiting. We also had a conversation with our UMMAs, the utilization management assistants, because they're the ones receiving all these letters, to keep an eye out. If it says inpatient approved, not just accept it as an inpatient, read through it, try to find, especially because we haven't seen any recently, so that made me worried. Are we missing out on these? And reached out to the appeals team and the billing team, making sure they're aware. And they also have a process in place, and there is an expected reimbursement. And if the reimbursement is less than the expected reimbursement, then it flags. So we have those lists already in place, and my take was, okay, as soon as you see any reduced payment than expected, let us know. And reading through the denial letters to see if we can clearly have that language separated out so that it's easier to identify which ones are considered low and which ones are considered high. Because it's not that clear cut in the approval letters sometime.
Yeah, no, I think you brought up some great points that we have also been implementing for our strategy to manage these, because as you pointed out, like these would be very easy to get lost in the shuffle as just inpatient approved. And we did have to do a lot of education with our team. We even had to do some modification to our EMR build to help us call these out and help us manage them. We created like a new category of denial. It's a low severity payment, so that our UMAs, when they got these cases in, instead of marking a medical necessity denial, they would mark it a severity, payment case, so that helped us flag, and that will help us with our reporting to be able to monitor the volume, monitor the outcomes. And then what we also found too, as we were talking with our denials and rev cycle folks, is that our normal processes to manage denials would not necessarily catch to these, because typically on the back end, your rev cycle team is responding to denial codes by your payer. And these type of severity downgrades on the payment are not going to come in with those same codes. So if your whole denial system is built around certain codes being present, you may not notice these cases occurring. You will see them as inpatient. You will think all is well, unless you have what you described, Sweta, which is a team or some sort of automation to focus in on expected payment and what you actually received. And then from there, you can potentially capture these cases. And I know for us, normally those type of payment cases, we would have worked by maybe denial nurses, more technical billing people.
Right.
And for this particular payer, we are going to opt for ours to send those back to our normal denial nurses, because our appeals argument will be based on clinical medical necessity, not on some technical billing thing that typically is what you find. So I don't know that, again, that's kind of what we're doing, early, is to try to figure out how to manage these. So
absolutely. I think these are definitely new changes that need new creative ways to capture them and be able to do, because I think, like you rightly said, first question that came when I shared this with our team is, so is it a denial, or is it because it's saying approved? Do you want us to send it to PA calling it as a denial need peer-to-peer? Or it's that, yes, treat it like a denial because it's denial for the severity payment model, even if it's not a denial for the patient class.
Correct. Yeah. I don't know. I think we're going to see more payers adopt similar, which I think that's going to potentially be challenging if we keep seeing more and more payers, because I suspect each will have their own nuances to it. And, that I think could be a challenge for health systems, hospitals, to try to manage that. If we've got, 5 different major plans out there with subtle nuances around this type of billing practice. So it's going to keep 2026 and beyond interesting, I think, for us in the space.
For sure. Thanks for bringing this case up, Rebecca. This is an interesting and important topic right now for us in 2026.
Yeah, no, and thank you for your input too. It's good to hear. I think that we're maybe on the right track, and based on what you guys are trying to do as well.
Thank you to everyone for joining us for another episode of Case by Case. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you are notified when we upload new episodes. Until next time, this was Care Transitions Today, Case by Case.